Hey, I am so happy to be here with you with our next section. Boy, diagnostic testing in renal disease. Look at this, a urinalysis. Boy, isn't this the right time to be pissed off? Let's look at a urinalysis. I'm a what? Urinalysis. What'd you call me? Urinalysis. No, I'm not. Yes, let's look at our piss together. Let's get pissed off together. Okay, urinalysis. Now, I love a urinalysis. Uroscopy, medieval. Look at this urine. It is so sweet, so sweet. Mellitus, sweet. Greek guys tasting urine. Diabetes, a Greek word for fountain. Mellitus means a sweet fountain. Diabetes, insipidus, a bland or insipid person, like Dan Quayle. Anybody remember him? So there is, as good as this is, two answers. One is it's the best initial test. One is it's the best initial test for all renal disease after BUN and creatinine. And at the same time, it is also not generally recommended for routine screening. So urinalysis is not recommended for everybody. In other words, if you're 50 years old and you haven't had a mammogram or a colonoscopy, I'm supposed to chase you down the street with that colonoscope. Here you go, hold still. No, not my colonoscope, no. And you're supposed to be able to run faster than the patient you're chasing with the colonoscope. Now, on the other hand, a urinalysis is not recommended for routine testing, meaning although it's the best initial test, I'm not supposed to have to chase you at any particular age. I'm not supposed to have to chase you at any particular age to have to make you do that urinalysis. If you come in and you say, well, since you are here with another kidney disease, would you mind making a little urine? No problem, best initial test. BUN creatinine urinalysis. However, not a routine screening test. Not like mammography above 40, pap smears at 21 to 65, or colonoscopy starting at 50. Now, the reason that we are screening is because in hypertension, and particularly in diabetes, man, we have an epidemic of diabetes. We got 10,000 new diabetics in the United States per week. You know how many people that is to go on dialysis? You know how many people that is that need new organs? Ooh, what a disaster. Because if this is microalbuminuria or any albuminuria, we need to be on an ACE inhibitor or an angiotensin receptor blocker to fix that. Let's look at this here. Microalbuminuria is 3 to 300. When it goes above 300 milligrams for 24 hours, that's considered trace. Trace is at 300. Now, mild proteinuria, 1 gram a day. 1 gram a day, 1 gram a day. Let's see, micro is 30 to 300. Trace is from 300 milligrams to 1 gram per 24 hours. 1 gram per day, if it was evenly excreted all day long, would make 1 plus proteinuria. 3 grams a day, if it was excreted evenly all day long, would be 3 plus proteinuria. 4 grams a day, if it was evenly excreted all day long, would be 4 plus proteinuria. What would you get in that urinalysis if you had 10 grams a day? You would get 4 plus proteinuria. You would get 4 plus proteinuria. Okay? You would get 4 plus proteinuria. 4 plus proteinuria. Okay? So therefore, 10 grams is 4 plus proteinuria. Now that means, why does it only go up to 4 plus? It only goes up to 4 plus because of nephrotic range proteinuria. Once you're nephrotic, it doesn't matter how nephrotic you are. Once you're nephrotic, it doesn't matter how nephrotic you are. I'm already nephrotic. How nephrotic am I going to be? Once I'm above 3.5 grams of protein per 24 hours, you already know that you're nephrotic range proteinuria. Did you know that when you get stressed, you have protein in your urine? Hell, I must have so much protein in my urine it comes out like Tasty Delight frozen yogurt. My level of stress. Arrgh. Well, fever, exercise, congestive failure. In other words, if there's increased flow or stress, it causes protein to go into the urine. Nobody really understands why. Nobody really understands why. Now, what happens if you have a little bit of trace proteinuria? A man comes and he's got a little trace proteinuria, or a little 1 plus proteinuria on a urinalysis. What is the next best step? Repeat it, repeat it. The man works as a waiter. The man films step 2 USMLE videos and he's on his feet all day long. What do? You split it. You split it. You split it to make sure it's not orthostatic. What does orthostatic means? Orthostatic means that when you're standing up all the time, you make protein more in your urine. When you're standing up all the time, it makes more protein in the urine. You split it. You see, orthostatic proteinuria is not that bad. Orthostatic proteinuria is more benign. It means you're just standing up. So we'd like it to be orthostatic because it's more benign. Now, hematuria. You'll notice that any form of trauma into the kidneys. Well, hematuria, let's look if we could find something for hematuria. We have stones. We have hematological disorders. We have infections that cause hematuria. Infections that cause hematuria. Any infection, kidney or bladder, kidney or bladder, kidney or bladder. Tumors like bladder cancer or renal cell carcinoma. Bladder cancer or renal cell carcinoma. Treatments like cyclophosphamide, hemorrhagic cystitis. Tumor trauma treatments. So what do we have for hematuria? Look at the hematuria. Look at this. All the things that cause hematuria. Yes, that is correct. All the things that cause hematuria. Stones, hematological disorders, infections, tumor, trauma, treatment, and glomerulonephritis. Now, how would you tell the hematuria of glomerulonephritis apart from the hematuria of these things? What's different about the red cells? The answer is they're dysmorphic. Those red cells have been squeezing their head through the glomerulus. And they're dysmorphic, changing their shape. Like a baby going through the birth canal. Dysmorphic, squeezing. Which way is the kidney tubule? Dysmorphic red cells. So they squeeze through the glomerulus. That's what's different. Glomerulonephritis, dysmorphic. Nitrites, you see that? Do bacteria eat nitrate? Do they eat nitrate or they eat nitrite? You ate nitrate and you make nitrite. You eat nitrate. So gram-negative bacteria will convert nitrate to nitrite. And what this is looking at the metabolic breakdown products of gram-negative bacteria. Basically, gram-negative bacteria ate the 8 and made the 8 out of the 8. How confusing. Cute. Now, that basically doesn't contribute very much to nitrites. It doesn't change a whole lot. The most important thing we look for in a urinalysis to indicate infection is not nitrites. The most important thing that we look at in urinalysis for a marker of infection is that we look for white blood cells. The most important thing that we look for infection is white blood cells. White blood cells equal infection. Eosinophils equals white blood cells equal infection. EO, here cell, there cell, everywhere cell. Old MacDonald had some white cells. EO. And on his urinalysis he saw allergic interstitial. Oh, an EO here and an EO there. Everywhere an EO. Ah, allergic interstitial nephritis. Yes. Allergic interstitial nephritis. Yes. Now you see this bacteriuria here? Bacteriuria? Bacteria in the urine. Very hard to get a clean catch, particularly in a woman. It's not exactly clean. You know what I mean? There's a little bacteria down there. A little cheesy. A little like yogurt. Okay, a little bacteria down there. Tasty. But not sterile. Okay? Like blue cheese. More taste, but less sterility in that urinalysis. However, bacteria in the absence of white cells. That's what we mean by bacteriuria. It doesn't mean bacteria with white cells, because that's definitely an infection. Bacteria with white cells, you're infected. May I have 3 days of Bactrim, please? Also, taste is so nice, so special for you. I clean out your urine be just as nice, as clean as the day you were born. What beautiful clean urine you have. 3 days of Bactrim. Lo, in the beginning there were 3 days of Bactrim. This urine shall rise again. 3 days of bacterium if there's white cells and bacteria. But what if there's just bacteria in the urine alone? We don't care in most people, except the pregnant people. See this thing about pregnant women? That's because 30% go on to pyelonephritis. 30% go on to pyelonephritis. You see, see where it says routine screening is recommended? Because if we find a pregnant woman with bacteria in the urine, she gets antibiotics. If Conrad Fisher has bacteria in the urine, they go, why'd you check my urine? Why'd you check my urine? But pregnant woman, you check. Why? Because you're going to treat it. Me, you wouldn't treat it. You wouldn't treat it. Bacteria in the urine, only in a pregnant woman. Nitrite, evidence gram-negatives. Protein, and it's mild, repeat it. Protein mild and still there, split it to see if it's orthostatic. Orthostatic is benign. Persistent moderate proteinuria. Persistent moderate proteinuria means time for a kidney biopsy. Kidney biopsy. Ooh, time to go down to central casting. And down at central casting, what do we find? We find that everybody makes a little protein. You know, even nice guys can make a little mucus. I make a little mucus sometimes. Look, there it is. But it's not pathologic because it's in small amounts. It's in small amounts, see? See? It's okay. Even nice guys can make a little mucus. But if I become dehydrated, pre-renal, hypovolemic, pre-renal, hypovolemic, hypotensive, pre-renal, my normal TAM horsefowl protein in the urine, TAM horsefowl protein in the urine, can accrete and become hyaline casts. Everybody makes a little protein sometimes, but if you're not pre-renal, it flushes right out. If you are pre-renal, you get hyaline casts. Red cell casts, definitely glomerulonephritis. Casts are like a pericardial friction rub. If it's there, it helps you. If it's not there, it doesn't mean anything. Doesn't mean anything. Doesn't mean anything. Do you see granular casts? You know what the granules are? The granules are little dead epithelial cells in the tubule. When the tubule cells die, they slough off and they form into casts. Granular casts is like a mass grave for tubular cells in the kidney tubule. The little epithelial cells accrete in a tubule and form a big stack, so like a stack of Oreo cookies in a way. So the granules, the dirt or the muddy brownness, is basically sloughed off dead epithelial cells. Now, eosinophil casts, which are not here, are indicative of allergic interstitial nephritis. White cell casts, infection. Red cell casts, glomerulonephritis. If they are there, they're very specific. Absence excludes nothing. 30% of people with glomerulonephritis have red cell casts. You have a 70% chance you might miss it on one urinalysis. You could have any one of these diseases without a cast. A cast means you got a disease. The absence of a cast does not exclude the disease. This is our waxy cast. Does that look like wax? Definitely. I feel like putting a wick in there, don't you? Oh, more hyaline casts. Remember, this is accreted protein. Accreted protein from inside the tubule. This is extra TAM horsefowl protein that's just getting crusty inside the tubule. Just means dehydration. That's the end of diagnostic testing. Remember, the urinalysis is a great test. It tells all sorts of nifty things. Red cells, infections, stones, hematologic, mostly stones, infections, and tumors. White cells tells infections. Eosinophils tells allergic interstitial. But we don't do a routine test. But in you understanding white cell infection, red cell, tumor trauma treatments, you understanding protein could be either mild or benign, or get me a 24-hour urine, man. The only point I want to make here about the protein is that when you see protein in the urine, you do not have to do a 24-hour urine protein. You do not have to do a 24-hour urine protein. You do not have to do a 24-hour urine protein. You do not have to do a 24-hour urine protein. You can do a spot protein or albumin to creatinine ratio. You see, the problem about protein is that during the day, over time, protein excretion rates go up and down and up and down because renal function varies in a day. When you do a spot protein creatinine ratio, it equalizes for the variation in renal function during the day. You see, renal function and the amount of protein varies in the day because renal function varies, so the amount of protein excreted varied. So the spot protein-creatinine ratio can compensate for the variations in creatinine during the day and renal function during the day. It can compensate for these. So spot protein-creatinine ratio has the same accuracy as a 24-hour urine. The spot protein-creatinine ratio has the same accuracy as a 24-hour urine. So therefore, why get a 24-hour urine? I wouldn't. I would get a protein-creatinine ratio. So ends another section of the nephrology section. The end of diagnostic testings. This is not the end of the nephrology section. This is not the beginning of the end of the nephrology section. But it is the end of the beginning.